Okay, we're started.
Thank you. Well, good morning and welcome. My name is Kathleen Borain and I am the Maryland Insurance Commissioner. I am pleased to welcome you today to the Maryland Insurance Administration's virtual public hearing on the 2022 Affordable Care Act rates proposed by Maryland health carriers. We're going to take a few minutes to continue to allow people to join, but in the meantime, let me go over a few housekeeping items with you. This year's hearing is being conducted on the Zoom webinar platform. The hearing is being taped and the tape recording will be made available for viewing on the MIA's website, along with any materials that are submitted. We have some individuals who have signed up in advance. We will, of course, hear from each of the carriers as they explain their filings. But in addition to that, we have invited the public, as we always do, to comment. Your thoughts, your views, your comments are very important to us, and we consider them seriously as we go through the rate review process. We do have a few people that have signed up to speak today. If you did not sign up, that's okay. If you would just indicate that you would like to be heard by typing "I wish to comment" in the chat box, to the extent that time and technology allow at the end of the hearing, and those who have signed up, we will invite you to speak. We'll unmute you and invite you to speak as well. If you're unable to access that function, or you're joining us by phone, you can still provide your comments by forwarding them to the Maryland Insurance Administration. At the end of our formal hearing today, we will have a slide that has contact information, so that if you do have comments that you want to make by email, or you have something that you'd like to put on the record, please feel free to provide your feedback, your thoughts, and your comments after the hearing. Finally, as we all have learned by now in terms of good Zoom hygiene, if you would keep yourself on mute throughout the hearing, unless you are speaking, when you're called upon to speak, then we'll ask you to unmute your line. As I noted, the purpose of today's hearing is to discuss the 2022 Affordable Care Act health insurance filing submitted by those Maryland insurers participating in the individual, non-Medigap and small group markets, which are before the administration for consideration at this time. I do want to make one sort of overarching comment before I turn it over to our Chief Actuary, Brad Boven, to provide a high-level summary of the filings. And that is that as folks in Maryland, including myself, experienced after the rollout of the Affordable Care Act in the individual market in particular, there were very, very high year-over-year rate increases. And one of the things that the Hogan administration did was to obtain a 1332 waiver and construct a reinsurance program. And the objective, the purpose of that program, was to reduce rates by an estimated 30% of the rates that were highest rates in effect. And then after that, once that sort of level set and that reduction occurred, was to see rate changes impacted primarily by actual cost trends. And also with the hope that as rates had been reduced, that the number of people in the individual market would increase and you would have healthier people, and therefore that would impact trends as well. So we've achieved that objective. It was a remarkable achievement, and that reduction of actually in excess of 30% has already occurred. And so we are in that place now this year where we have achieved that over 30% reduction in costs in the individual market. And going forward, what we would expect to see are adjustments year to year that are tied primarily to the costs of care. And so I want to make that really clear going into it in terms of what our expectations are as we review the rates this year in this new place where our primary focus is on cost trends. So Brad, let me turn it over to you to provide more precise detail about that element of this year's review, and also talk more generally about the filings.
Thank you very much, Commissioner. Craig, you're going to run my slides, correct?
Yes, that's correct. We'll share our screen.
All right. Well, first I'll just introduce myself. I'm Brad Boven. This is my first rate hearing as the Chief Actuary. I took over for Todd Switzer, who is now with Hilltop. I've been working for the MIA for about 4 years, though, in the individual marketplace, ACA primarily. And I've been heavily involved in the 1332 waiver and working with the exchange on stabilizing this marketplace. So, this is a market I'm very familiar with. So, Craig, if you could go to my first slide, please.
Yes.
Actually, page number 2. Thanks very much. So I'm going to start talking about the individual marketplace. So in bullet point 1 here, we have that the average rate increase being requested is 3.9%. That's a little bit higher than the 3.5% in our original press release. That can be explained by CMS changed the risk adjustment model for 2022 the day before filings were due. So all the carriers had to submit filings with old, outdated model coefficients for 2022. So one of the first objections we put in was to ask carriers to update it for the finalized coefficients. And so the difference between the 3.5 and the 3.9 is attributable to those CMS numbers. And so the 3.9 is what would have been filed originally had CMS, published their coefficients in a timely manner. There's a wide range by carrier of what is being filed here for this 3.9, from minus 11.5 to plus 8.5%. As far as enrollment goes, we've seen a large growth in enrollment between 2020 and 2021, almost 19,000 increase in members. And when you look at this membership growth by APTC status, you see that the large majority of them, 75–80% of them are not subsidized, which means, they are the people that the reinsurance program is lowering rates for. So while, a lot of these members came in during the COVID special enrollment period, they are for a large part not subsidized. And so this does show that, the reinsurance program is working in its goal to attract new members into the marketplace. And furthermore, those new members are somewhat younger and healthier than average. And so this average 3.9% request is a little bit below trend. The average trend in the individual market is around 5%. And so that difference, the lower than trend increase is mainly attributable to, the improved morbidity from those new entrants that came in the last year. One thing to note is that these rate increases are for the unsubsidized rates. And for the marketplace as a whole, only about 40% of members are paying the unsubsidized rates, and the other 60% are receiving federal subsidies. For those 60%, the American Rescue Plan was passed earlier this year, and it greatly increased the amount of federal subsidies available in both 2021 and 2022. So as a side effect of that, we are seeing new continued enrollment growth in 2021. Enrollment was declining before the American Rescue Plan started between January and March, but in April through June, we are now seeing enrollment start increasing again. And the second point there is that for those people that are subsidized, 60%, a lot of members were able to get the increased subsidy mid-year by going back to the exchange and reapplying. But as far as what they're going to see in open enrollment, 2022 open enrollment subsidized rates are going to be significantly lower than 2021 open enrollment subsidy rates because of the American Rescue Plan. Double-digit decreases there. One more thing to note is that United Healthcare, doing business as Optimum Choice, they are expanding from 14 counties where they offered in 2021 to being offered throughout the state, which is good news. There were still eight counties that CareFirst was the sole carrier in, and so it's really good to see increased competition. There is going to be an impact on the APTC because of this, but that's going to be largely offset by the American Rescue Plan. And so, Craig, if you could please go to the next slide. In the other ACA marketplaces, as far as small group goes, the current increases proposed stand at 7.3% versus the original file 7.2. Once again, it's the risk adjustment model there that changed. And once again, there's a wide range by carrier from minus 22% to plus 16%. As far as enrollment goes, small group did see some decreased enrollment over the last year, a 13,000 enrollment loss. That's not completely surprising, given what happened to the economy during the pandemic. We would like to see that number rebound, but that is something that is coming into play in the carrier projections, and playing into morbidity projections for the small group marketplace. And finally, we have the dental standalone individual plans. On average, there is a 0.3% modest small rate increase being filed for dental. And we've also seen enrollment grow by 5,000 members there. By 5,000 members, which is a 25% increase. And so in general, it's good news on the dental plans. If you could please go to the next slide, Craig. A big aspect of 2022 rate filings that is unique to this year and it is something new for the carriers to tackle is adjusting for COVID impacts. And there are three main types of COVID impacts in these rate filings outlined here. The first and biggest magnitude adjustment is to account for the fact that in 2020, the experience period, every carrier saw a pretty significant decline. 23% on average in individual, 27% on average in small group. In April of 2020, when the pandemic lockdown was underway, and a lot of hospitals canceled all non-emergency procedures, and people stayed away from doctors' offices in general. And so this decline was very large in April and May, started to rebound in June. Carriers report different months of when they think that the claims got back to normal level, somewhere in the third quarter 2020 to first quarter 2021 range is when claims got back to their normal level. So because of this reduction in claims due to people staying away from doctors, there's an additional adjustment needed to bring the base period up to what would have happened without the pandemic. And, we don't expect this, lockdown to reoccur in 2022. And so to have a valid baseline for applying trend and morbidity to, carriers are making an adjustment to account for the deferred claims in 2020. Those adjustments range from, just under 4% to just over 13%. The second type of impact from COVID is a worsening to morbidity due to missed preventive care in 2020. So to the extent that people did not have cancer screenings and other type of preventive services done, there have been conditions that were not caught early and are going to show up in claims as higher cost, more intensive services needed for the people that did not catch things and prevent things. And so right now, these adjustments are on a magnitude of 1% for what the carriers are building in. But it is something that's being monitored. There's also the potential for longer term costs for people that actually were diagnosed with COVID, the long haulers. And so this is a factor that's going to come into play over the next couple of years as we watch how COVID plays out longer term and how the longer term health impacts of this pandemic has on the membership. And finally, there's an adjustment for new COVID related costs, such as vaccines is a big one. They're currently being paid for by the federal government, but that's not expected to last long term. And so it's reasonable for carriers to start projecting costs for boosters in the future. And testing is another COVID related costs that, even though it happened in the experience period, it's reasonable to expect that there could be increased testing in the projection period. So right now, one carrier is building in a 2% adjustment for these type of COVID costs. And several other carriers have discussed them qualitatively and said they are monitoring their 2021 experience and may include something in the future. And once again, these types of costs could be in the longer term beyond just this 2020 rating year. And so this is how COVID has changed the landscape and changed how we're analyzing the data. Craig, if you could go to the next slide, please. Other than COVID, the key assumptions here are a pretty similar list to what's been there for past years. Trend is a large assumption. In general, trends have been going down, especially drug trends have moderated from where they were in a couple years ago when drug trends were running very high double digits. And so carriers in general are reporting lower trends. For morbidity, as the commissioner talked about earlier, prior to the 1332 waiver being put in place, morbidity was really spiraling in the individual marketplace. Every year there was large lapses of membership and double-digit worsening of morbidity. And the data has been showing that's really changed under reinsurance, that in 2019 and into 2020, the morbidity has really stabilized, the lapses have stabilized, and the morbidity has actually started to improve slightly, due to these younger, healthier members. And so, this is a big key assumption for the 2022 filings as well. We're continuing monitoring monthly enrollment and trying to get data about the latest enrollment to see if these new members coming in, with higher American Rescue Plan subsidies are, the same morbidity as the pool, or slightly healthier or slightly sicker. And so this is a big assumption that's in play in the rate filings right now. Risk adjustment, in addition to the coefficients the CMS released for 2022, that there's also, the 2020 starting point. CMS just released those 2020 actuals on June 30th. So we've asked carriers, to provide us all their detailed actual risk adjustment reports. And we've just received those, and we're currently reviewing them and seeing how they compare to the, projections that are in the original filings from May, and seeing where risk adjustment may need to change for 2022 based on 2022 changes. And then there's reinsurance. That's the individual marketplace only. But, for 2020, reinsurance has come in higher than originally projected. It's coming in at about $400 million versus an original projection of $387 million. It seems like a lot of that is due to COVID. And so we're still closely analyzing and looking at how carriers are analyzing, projected reinsurance costs for 2022 to make sure those projections are reasonable and don't rely too heavily on 2020, which is COVID influence, and taking into account where 2019 was and where 2021 is expected to be. And so, Craig, if you could please go to the next slide. That was a high level overview of, the rate review and where we're at and the assumptions we're focused at. Didn't get into any of the carrier specific rate increases here. Each carrier has sent a representative. They will be speaking about the rate increases that they are proposing. But if you have any questions about anything that I presented or any questions about the rate review in general, please feel free to contact me. My contact information is here. And any public comments are still being accepted. To date, we've only gotten 2 public comments to date, which is a little bit lower than past years. We welcome any and all comments. And so if you have any feedback after this hearing, please feel free to use our website and submit a comment. And you know, it does get back to the office of the chief actuary, and we do review these and take them into account when we're doing our rate review. So with that, that ends my presentation. So I'll turn things over to the commissioner again.
Kathleen, you're muted.
Thank you. Someone's got to do that. It's just a tradition, right? At least one person. So thank you, Brad, for that very thorough presentation. What I want people to remember is that what Brad has talked about has obviously talked about the trends. He's talked about the filings in general, and he's talked about what's been requested. But what has been requested is not necessarily what's going to be approved. So Maryland's rate review laws provide that only those rates approved by the insurance commissioner may be charged to policyholders. And before that approval, all the filings go through a very comprehensive analysis of the carrier statistics and assumptions. Obviously, we consider public comments as well. So ultimately, we are in the middle of this very thorough, analytical, detailed, granular process. And when we have completed that process, then that's when we will decide which rates, what rates will actually be approved. So the ask is not necessarily the grant, and we have consistently approved rates that are lower than those requested. So I just want to make that clear that we are still in our review process, and none of the numbers that you've heard so far are the numbers that have actually been approved. They are the numbers that have been requested. We expect that the approved health insurance rates will be announced just after Labor Day. So as we move into the next part of our hearing this morning, let me just take a second to introduce the members of the insurance administration who are with me today. You've met Brad Boven, our chief actuary. Let me introduce my chief of staff, Corey Boone. We also have Associate Commissioner for Life and Health, David Cooney.
Good morning, everyone.
Our principal counsel, Van Dorsey.
Morning, everyone.
I'm not sure if we have Adam with us today. Adam Zimmerman is our senior actuary in the individual market.
No, I don't believe Adam's here.
Adam is on paternity leave, so we wish him the very best with his new family. And we have Henry Wakama, who is our senior actuary for small group market.
Thank you.
And Michael Patty, our director of government relations.
Good morning.
And you've met Craig who is our director of communications. That slide that Brad showed at the end will go back up so that at the very end of the hearing, so that you'll know how to contact Craig and how to contact Brad and how to send comments to the insurance administration. Just as a brief reminder, the hearing is being recorded and it will be posted to the administration's website. With that, as indicated, each of the carriers who have made filings today will be making a presentation. And I would just ask the carriers that as I call the carrier name, you could, whoever's going to speak this morning, could introduce yourself, provide your name and your position with the company, then that would be very helpful to us. So let's start with, I believe, Edna. So we have someone speaking for Edna this morning.
Hi, bear with me. I'm
That's right.
managing the machinery here.
It's our new normal.
I'll put on. Okay. My name is Steve Schneider. I'm the actuary at Aetna who, oh, hi, can everybody hear? Yeah.
We
sorry,
can hear you. We don't have a visual. Is that intentional?
No, I can find that. Hang on. Let me do that. I'm happy to do that.
There you go.
Am I on? Okay, let me make sure it's centered correctly. Okay, very good. Thanks. So, yeah, again, my name is Steve Schneider. I for Aetna CVS, and I'm the actuary in charge of the ACA pricing. And we're only in the individual market. So I know there was some talk about we're only in the small group market. I apologize. I know the talk was about the individual, but we have a few members in the individual. So, so first of all, thanks for the opportunity to present information on our rates. And as the CVS company, as I mentioned, we're working hard to make healthcare simpler, easier, and more convenient for the people of Maryland. We are in the small group market for two legal entities. Our HMO entity is Aetna Health Incorporated, and the PPO is Aetna Life Insurance Company. And we have approximately 417 individuals in Maryland that are covered as of May. So I want to start off saying to note that what we're going to be talking about is the average rate changes here. The exact change will depend on what benefit plan the individuals choose, when the contract renews, the age and family size for enrolling employees, and employer contributions. To develop the rates, we take the adjusted historical claims experience from 2020 projected forward to 2022. And there are 5 main drivers for the rate changes, including the medical costs rising, plan design changes, estimates of the average morbidity in the risk pool, changes in taxes and fees, and probably most important, other items that such as the difference in experience from expected, and then COVID impact is in there. So I'll discuss all those in detail in just a sec. For HMO, the average is going to be a decrease of 22%, and for PPO, our average rating decrease will be 6.9%. For simplicity, from here on, I'll talk about the entities together. I'll average them, and together that makes a decrease of about 8.9%. We have 8 plans filed for HMO and 3 for PPO. All 3 of the PPO and 3 out of the 8 HMO are both on and off exchange, and the remaining 5 HMO plans are just off exchange. So as I mentioned, this is a weighted average of year over year, and the exact rate change will depend on those factors mentioned above. The first quarter we'll see, for first quarter, it will be an average of a 22% decrease and a 6.9 for HMO and 6.9 decrease for PPO, as I mentioned. So I'll talk about the main drivers in a little more detail. Now, medical and pharmacy costs, they increase for 2 reasons, as I think everyone knows. The providers will raise their prices and members get more care. Our projected paid trend for medical, for just the medical, is 10.1. For drugs, it's still high at 14.3, and that the total is 11.1%. Plan design changes, we made cost sharing changes to some of the plans to comply with the AV requirements and or to make them more attractive to consumers. And on average, this increases costs 0.7% for HMO and decreases at 1.5 for PPO, for a combined decrease of 1.2%. The morbidity of the risk pool, our estimate of the average is population health and expected risk transfer payments for ACA products. They've changed to reflect new data on average premiums and population health. Small groups purchasing in the marketplace are expected to be less healthy than initially anticipated, and we think these changes will increase costs by about 2%. Changes in taxes and fees are minor. We have a charge of 23 cents PMPM, or 0.05% of premium for the reinstatement of the Patient-Oriented Outcomes Research Institute. For 2022, that's coming back. And finally, the other items, our claims experience, our actual and projected, is different from what we expected, and that, along with a couple other items, have decreased. Have contributed to a decrease of minus 21%. So those are the drivers of the increase. And so we also wanted to take some time to say to let you know what Aetna is doing to keep premiums affordable. We are taking a lot of steps to keep our products as affordable as possible to address the underlying costs of healthcare. And these actions include things like developing new agreements, arrangements, and partnerships with healthcare providers, that base arrangements that base the compensation on quality of care and not just the quantity of services. And as well, we're creating medical management programs that address potential health issues for members earlier and improving the outcomes and reducing the need for healthcare services. So there's my comments briefly. And again, we just want to thank you for the opportunity to present to you today. So thank you.
Thank you very much. Brad, did you have anything?
Yeah, thanks very much, Steve. I do have just a question or two.
Okay.
So for the claims experience that they came in significantly better than expected, the minus 21%, do you have any indication of what the main driver of that was? Was it better morbidity, younger demographics, lower trend, lower risk adjustment, some combination of the above?
Yeah, probably about half of that, I'd guess, is the risk transfer payment came in better for 20 than we thought. We had a lower projected, I think one of the entities had a payable, one had a receivable in last year's rates assumption. And what we got for 2020, the actual was receivable for both. So that comes into play a lot. And the rest, the rest of it is, a lot of it's just volatility. We only have a handful of members, so we have to use a proxy, and we use large group experience and we adjust it. And some of it's that changes, but some of it's just frankly the estimate of how we translate that to small group via morbidity adjustments and such. And that's a little bit lower than last year as well. Okay,
thanks. And so that was kind of another question. So you're using large group as your manual component of rating, since
yes,
you don't have a credible block here. So when you're talking about like the trend, you use your large group data as the basis for your trend development.
Yes, yeah.
And that's large group Maryland, right? Not large group nationwide.
It's Maryland. Yeah, it's Maryland. Yeah. We figure we assume Maryland it's sort of a catch-22, right? Because it's a different market, but it also reflects our provider contracts to the best. So we figure it's best to adjust that way than to try to use other experience from other states.
All right, thank you, Steve. That's all the questions I had. I don't know if you had anything, Henry.
I think I'm good. Thanks.
Okay, thank you. Thank you very much. We appreciate your presentation and your answers. So thank you very much. Somebody just muted me. Can you hear me now?
Yes, we can hear you now. Thank you.
Okay, it's telling me I'm muted, but so we'll now hear from CareFirst Blue Cross Blue Shield. I think that's Mr. Barry is going to speak.
It is. Thank you, Commissioner. My name is Pete Barry. I'm Chief Actuary at CareFirst, and today I'm going to be talking about CareFirst's proposed 2022 ACA rates for the individual and small group market. CareFirst offers ACA rates in 3 entities: our HMO POS plans under Blue Choice and our PPO plans under CFMI and GHMSI. So let me start with individual. Start with Blue Choice. That's where the majority of our membership resides. As Brad said, our proposed rate increase is currently at 8.5%. And I'll just walk through some of the drivers for that. We did see a deferred care in 2020. And so we were able to make an adjustment to the 2020 base period to adjust that to a more normal level before projecting like all the carriers did. And then on top of that, our run rate trend that we used to project out to 2022 was 5.5, very close to what Brad had talked about with the 5%. I think it's important to reiterate something the Commissioner spoke about to begin with regards to the 1332 in the last 3 years and hitting a new level. So just a brief history, back in 2019, the 1332 was proposed. What followed was 3 years of double-digit rate decreases for the carriers, and to land to that new level. And we agree with MIA that we have landed at the new level, and now we would expect going forward that we would see rate increases about equal to trend, all things equal. One thing that also should be reiterated is the stability of the morbidity in the pool, whereas before the 1332, we saw dramatic swings in morbidity year to year, which was driving very big increases in the selection spiral. We're seeing very small changes in morbidity relative to that now, which is great in that the rates are much more stable. So if we think about the drivers for the 8.5, what we have seen in the last couple of years as we have lowered rates and our rate position has improved is we have seen an influx of healthier members into Blue Choice, which has taken us from a risk adjustment receiver to a risk adjustment payer. And when we become a risk adjustment receiver, when we were a risk adjustment receiver, that brings rates down. And as we shift to a risk adjustment payer, that tends to drive rates up. The other piece to consider here is that while the 2022 rates are developed off projected claims, the rate increases we're talking about are relative to 2021 rate levels. And so while the 2021 rates don't impact the 2022 rates, they do impact the change. And what we're seeing emerging for 2021 in Blue Choice is a loss. And so our most recent projections done with 3 months of data to the end of the year show about a -4% loss for that block on a run rate basis before MLR rebates. And we'll update that as we go through the year. What that means is the starting point for 2021 is lower than it otherwise would be. And this isn't necessarily completely surprising. Nothing is sure, but at the end of last year, it looked like the rates have been pushed a little bit lower than we would have liked. And we set up a premium deficiency reserve to offset that. So it's not completely unexpected. But what that means is that 8.5 is relative to a rate that's slightly too low. And so if you think about 2021 had been adequate, they would have been slightly higher, and the 8.5 we expect would be somewhere around trend, 5 to 5.5, which is great. I mean, that's exactly what we would hope for. But it does hit home the point, and this was very evident back before the 1332, that adequate rates are very important. Where you might get a rate in the market that's lower one year, it can lead to higher increases the next year, and that can cause instability. So we are seeing that with regards to that 8.5. We think part of that is that some of the factors for 2021 were too low. Specifically with regards to risk adjustment and morbidity, those are generally offsetting, which is nice. And you would expect that as your morbidity improves, you would expect to pay more in risk adjustment. And we see that with Blue Choice, where morbidity we expect to decrease by about 3.5%. And we expect the risk adjustment to go up by about 3.5%. So that's the kind of stability we're looking for. Along with those healthier members, though, we are anticipating we will get slightly less reinsurance, which is adding about 2% to the rate as well. So at the end of the day, we're at 8.5 for Blue Choice. For PPO, it's a little different story. We have about 12,000 members in PPO. They tend to be about 3 times the morbidity or illness burden of the Blue Choice members. And so they tend to be a lot more unstable. And what we're seeing there really with a -11.5 and with updated numbers towards the end of last week, that's come up a little bit. It's about a -7.9 now. And again, we'll continue to work with the MAA through August to get final numbers, but we'll work with the -11.5. What we're seeing really driving that is those members are deteriorating in morbidity. And what that means is that we get more reinsurance. And so that's driving the rates down by about 6%. As the reinsurance kicks in on sicker members. And also as they get sicker, they get more of a risk adjustment payment. And that's about another 4%. And so that's really driving those decreases. That sounds like a lot, but I think it's really important to understand the relative changes of some of these rates. And just for those who weren't around a few years ago, in 2018, the MAA approved a 49% rate increase for PPO. That was the normal back then, was to have these massive swings. So to be able to get a single digit change either way in PPO on a very small volatile block is a testament to the stability of the 1332 waiver. So there's the individual. We pause there, and I'll see if you have questions before I move on to small.
Brad, do you have anything for this hearing?
The only question I have is you can talk a little bit about how COVID is impacting our
Sure.
emerging experience.
Yeah, let me do that. Let me talk about small real quick, and then I'll talk about the 3 points you had brought up about the ARPA and the COVID costs, because those apply to both. So I can do that. For small group, we're very pleased with the stability that we've seen in small group. Again, we offer HMO POS plans in our Blue Choice and PPO plans in our GHSMI and CFMI. Most of the membership is in Blue Choice. PPO is about 1/10 the size, and so it tends to be a little bit more unstable. But with Blue Choice small group, we're at 5.4%, very close to run rate trend. That has been low to mid-single digit increases in that block since 2015. So we're very pleased about the stability there. And that's generally what we're talking about there. It's generally driven by trend on the Blue Choice side. If we think about the PPO, it's running a little bit hotter, around 7.9. And what's really driving that is, again, it's a smaller box, so it's a little more unstable. And what we're seeing there is that the risk adjustment receivable is coming in a little bit less than we had anticipated in prior years, and that's adding a couple points to our rate. So it's really about trend and catching up on that risk adjustment. So that's small group. Then let me address, Brad, what you talked about with COVID, and I want to talk a little bit about some of the early ARPA impacts we're seeing, and potentially, do we see anything on the Young Healthy state subsidy? Now, we only have May data, so it's very, very preliminary, and we're going to be continuing to update that once we get June data. But first, on COVID costs. So as everybody knows, last year around March, we saw care really fall off through May, as Brad described. We did see it come back towards the end of the year. It was very interesting. We returned to expected levels in 2020, but the makeup of the claims were very different. It just so happened for the latter part of the year that the deferred care that wasn't happening was generally almost exactly offset by the COVID costs for COVID care and testing that were occurring. And so we returned to what looked like normal levels through 2020. Then moving into 2021 for January and February, they kind of continued, when all of a sudden we saw a big spike in March to a new level. And that, while that was higher, it did come down a little bit in April, May, June, but still higher than the historical levels. So we started looking into that to see what was driving that. And there were a few things driving that. One was that we had some initial assumptions that any deferred care would be offset by COVID costs. And as deferred care came back, the COVID costs would subside. What we believe is happening is that for everyone who's going in for the deferred care that's returning, they're getting tested. And so we have a little bit of this double whammy of the deferred care returning and the COVID testing continuing. We do see, and this is very preliminary, and again, we're going to update it once we have June claims pushed through our systems, but we do believe we are potentially seeing the instances of what we talked about with deferred care coming back and what was called the cancer time bomb. First one is we are seeing in March, an example would be we're seeing a higher than expected on obesity surgeries, which would be, and when we go back to look at obesity surgeries from March to May 2020, we see a precipitous drop. And so it's not surprising that as things are opening up, we see those coming back. That's an example of the deferred care coming back. We're also seeing, and again, very preliminarily, we're seeing a slight bump in cancers for female reproductive, which is concerning. And this goes to what Brad was talking about with regards to testing that was skipped in 2020 that could lead to what you'll see in the media is called the cancer time bomb. So both of those have potential to increase trends in 2021. The former, the deferred care coming back, the question will be how long will it take? Will that be a bump in 2021 and then will it settle back down to 2022 and we'll kind of push through? The second one's a little more concerning is if we do have higher morbidity because now we have more cancers in the population. So we'll have to pay attention to that very closely. So those are the COVID impacts. With regards to the American Recovery Act and the Young Healthies, we have 1 month of data that the trend does not make, but we'll continue to watch it. We are seeing some things though. We wanted to look to see if we're getting younger than average members in our new members for May. And we have slightly more new members in May than we had in other SEPs for the previous few months, February through April. We were running around 27 to 2,900 members per month, and we had 3,100 in May, so slightly higher. But we did not see them have a lower average age. Their average age was pretty much in line with prior SEP months, and we did not have a higher percentage of under 30s that would reflect the young healthies. Now, again, it's the first month of the program, so we can't really judge it off that. We're looking for indicators, though. We did see, though, a little bit of evidence that the APTC increases were having some impact. And the way that manifested itself was we had been running around 85 to 87% on exchange for the SEPs, and we were at 90% for May. Again, a slight bump up could be an indicator. The other one indicator was we were running anywhere from 10 to 15% on silver CSR plans for new members, and that hit 18% in May. So there's two indications that the increased APTC subsidies could be having an impact. Now, it doesn't necessarily mean that it impacts morbidity one way or the other, but it does look like that those increased APTC subsidies may be impacting who's signing up. So there's the discussion of those two, and I'll be happy to take any other questions.
Thanks very much. That was very informative. The only other slight question I have is, for the PPO and the individual market, with the rates decreasing, the enrollment has ceased its decline and it actually has started to grow a slight bit. Do you anticipate any meaningful enrollment growth, or do you think it's going to stay at about the level it is right now?
Yeah, that's a good question. It's amazing how stable that enrollment has been, right around 12,000, even through all the tumult of all the big increases and then the big decreases over the years. We've looked at who those people are. They tend to be two blocks of people. They tend to be people who just are relatively healthy, but want to buy the best possible coverage they can. And so they can afford it. And then it tends to be people who are very, very sick. We used to see quite a bit of turnover in that segment, even though the total stayed about the same. I don't anticipate, given the differential in rates, I don't anticipate that a 10% drop relative to Blue Choice is going to have a huge impact. Again, I think for most people, you're talking about the upper end of the pyramid here with regards to illness burden. Most people are going to find the Blue Choice product much more amenable. So I don't necessarily think there's I don't think there's a huge market out there for very expensive PPO rates, but we'll watch it very closely.
All right, thank you.
Sure.
That's all the questions I had.
Anybody else from the MIA? I just had one question. Pete, how much of the 8.5 increase is reflective of what you have characterized as a premium deficiency?
Yeah, it's a good question. Some of it could be that we're seeing the higher claims coming through, maybe about 0.5 point to a point compared to what we thought. It's hard to tease. We'll have to tease it out by factor once we get our 6+6 update, but I could easily see that 3 to 4 points of it.
Thank you. That's the only question that I had.
Okay. Well, thank you very much. I appreciate the opportunity.
Thank you for the presentation.
Sure.
Brad, I'm not going to stop and do it now, but at the end of the presentation by the carriers, I will ask you to just touch slightly on some of the points that Mr. Berry was making about the impact of the of reinsurance and also the impact of the risk adjustment payments, to make sure that folks who are on today kind of understand the concept. I think more of the risk adjustment payments than the reinsurance and how that can factor in. So if you don't mind, I'll ask you to kind of wrap up with that. So our next carrier is Kaiser Permanente. So happy to hear from someone from Kaiser.
Hey there, this is James Chu from Kaiser. I'm a senior actuary there, second year working on Maryland rate filings.
Hi, thank you, Mr. Chu.
So I will address the individual filing first. This rate filing represents 17 plans offered both on and off exchange, with minor changes to keep plans within the appropriate actuarial value range. We added 3 new plans, including 1 gold plan and 2 silver plans, offered both on and off exchange. And these plans currently service approximately 60,000 members throughout Maryland. For 2022, we have currently filed for an average rate decrease of 5%, though depending on the exact plan, rate decreases may range from 3% to 7%. The state-based reinsurance program has had a significant impact on rates, and without this program, our estimate is that the 2022 rates would need to be 35 to 40% higher than filed. For the small group market, our filing represents 62 plans, including both on and off exchange and 2 different provider networks. For 2022, we removed 2 plans with low membership and added on and off exchange versions of 2 new plans. These plans currently service approximately 11,000 members throughout Maryland. We initially filed for an average rate increase of 0.5% for 2022. The rate changes vary from -1% to 6% depending on the plan and when the group renews. In 2020, Kaiser Maryland saw a high amount of COVID claims for the ACA markets, which was partially offset by deferred care. In certain instances, we used a lower inpatient trend as we expect these costs to normalize in 2022. Kaiser's professional costs, on the other hand, are to some degree insulated from both increased COVID claims and deferred care, as our professional costs are primarily fixed as opposed to a typical fee-for-service model. COVID testing and vaccine costs are also down from their peaks, and we expect them to remain low in 2022. In typical years, membership in Kaiser's individual market line of business decreases monthly throughout the year. Thus far in 2021, we saw a dip early in the year, followed by a subsequent uptick in membership that we attribute to the American Rescue Plan's extended ACA open enrollment and increased premium subsidies. We expect that the American Rescue Plan will contribute approximately 5% growth in individual market membership. This concludes my prepared comments.
Thanks, James. I have a couple questions for you. The first is, can you comment on any kind of enrollment trends you're seeing in 2021? I know I see on television Kaiser advertising the American Rescue Plan subsidies and encouraging people to re-enroll. And do you know how successful that effort has been?
Yeah, again, we still have very little emerging data in terms of when the American Rescue Plan has been active, but just comparing the seasonality of 2021 to prior years, it looks like it's been about a 5% of a bump, but it's still pretty early.
All right, great, thanks. And on the topic of COVID, I just so everybody understands, so with respect to your COVID claims, you have seen the same kind of utilization reduction that other carriers have seen, but you're saying that it doesn't impact cost the same for Kaiser, since to the extent that your staff model, your costs are fixed no matter what the utilization is. So the declining utilization didn't lead to a decline in claims costs to the extent that a pure fee-for-service carrier. Is that a correct characterization?
Yeah, that's exactly right. It doesn't really matter how many times, to a certain extent, our members see the doctor. We generally compensate the doctors with a fixed monthly rate. So even though there was, people definitely saw less of their physicians in 2020, that isn't really flowing through into our costs for 2020.
All right, and to the point that Pete made about increased testing along with care that had been deferred, do you know if your Kaiser medical centers are requiring testing for all patients, and is that part of what's already been built into your claims trend if you are requiring testing for everyone?
I'm not sure about the exact testing requirements, but we did see a lot of testing at the end of 2020, and we are still seeing about $5 to $10 of testing PMPM going into 2021, which is obviously still like a bit higher than expected. It's really hard to say, where we will be in a year and how much money we'll still need to be spending on testing and what our testing policies will be in terms of when they come into our facilities and, the general public interest in testing as well. Like, will they still be wanting to do that in a year? Who knows?
All right, thank you.
Okay, anyone else on the MIA team have any questions for Mr. Chu? Okay, well, thank you very much for this morning's presentation. And we will move on to United Healthcare.
Yeah, can you hear me okay?
Yes.
Terrific. Good morning. Thank you to Commissioner Borain and to the Maryland Insurance Administration for the opportunity to present today. My name is Ryan Morgan, and I'm an actuarial director with United Healthcare, and I'm here to discuss the 2022 small group and individual rates that United Healthcare has filed with the MIA. United Healthcare continues to offer small group policies on 4 legal entities: United Healthcare Insurance Company, Mamsie Life and Health Insurance Company, Optimum Choice Incorporated, and United Healthcare of the Mid-Atlantic Incorporated. Across all 4 of these legal entities, we are proposing 87 unique small group plans in 2022 that span all metal levels: 11 platinum, 39 gold, 32 silver, and 5 bronze. Approximately half of these plans are available both on and off exchange, while the other half will be available off exchange only. In the small group market for 2022, we submitted our rate filings back in May and requested the following rate increases: 12.3% for United Healthcare Insurance Company, 13.7% for Mamsie Life and Health, 13.8% for Optimum Choice, and 16.0% for United Healthcare of the Mid-Atlantic. And let me be clear that these figures represent the average rate change for each respective entity. The requested rate change for any group could be higher or lower depending on a variety of factors. One of the primary drivers of our requested rate change is our trend rate. United conducted a full review of the components that contribute to trend using the most recent information. We analyzed unit costs, utilization of healthcare services, the impact of deductible leveraging, and all these components were looked at for inpatient, outpatient, professional pharmacy, and other services. Based on this analysis, we filed for a trend rate of 7.9%, which was reflected in our rate filing. One other factor that was mentioned by Brad earlier in his remarks that's unique to this filing was the impact of the COVID-19 pandemic on claims in the experience period. Claims were relatively low in some months, particularly in March through June of 2020, due to measures taken in response to COVID. Therefore, an adjustment to our 2020 claims level was made in order to make it a fair baseline for our 2022 rating period. So then turning to the individual market, United Healthcare is continuing to offer policies on the individual exchange after re-entering in the market in 2021. We are selling plans statewide just under the Optimum Choice Incorporated license, so just that one license. We're offering 11 individual HMO plans in 2022, 4 gold, 4 silver, and 3 bronze, and all of the associated CSR reduction silver variants. We submitted our 2022 rate filing with an average increase of 1.7% for our individual block of business. And the same caveat as earlier applies, this is an average, so the rate change will vary based on the individual's plan selection and other factors. As was the case last year, we don't yet have a credible in-force block from which to develop our pricing because we just re-entered last year. So we've utilized the data and expertise of Wakely Consulting Group Incorporated to build our Maryland pricing portfolio. Premium rates were developed using a rating manual built from Wakely's WACA database of individual ACA data. The rates were developed using this experience data combined with knowledge of the Maryland marketplace and informed by individual rate filings, risk adjustment reporting, and other publicly available materials. The primary driver of our rate increase is the application of an additional year of trend with adjustments for abatement and pent-up demand relative to COVID-19. Additionally, our rates do reflect expected changes to market morbidity as a result of Maryland's enhanced young adult premium subsidy program and enriched subsidies as a part of the American Rescue Plan. So hopefully this summary of United's 2022 small group and individual rate filings has been helpful. I'll happily take questions regarding our small group rate filings. I was the signing actuary on those. We actually have 2 people on the line. I'm not sure if they're presenters. I'm not sure if they can talk. So I'm not sure if there's a way to give them access, but Catherine Simon from UHC, and also Adam Rudin from Wakely Consulting, I know are on the line, and they would be more the ones that have information available on the individual rates. So yeah, thank you very much.
Thank you, Ryan. I don't think I have any questions on the individual rate development per se. I think I do have just one question at a high level. It's great to have, have you in the individual marketplace offering the optimum choice HMO. You have 4 legal entities in small group, including an EPO and a PPO. Are there any longer term plans to offer a PPO in the individual marketplace?
Yeah, that's one, yeah, I couldn't speak to because I don't know if Adam or Catherine, if there's a way they could.
Hi, yes, this is Catherine.
Oh, great.
Yeah, currently we don't have any plans. We wouldn't rule it out entirely, but there's nothing in the short term.
All right, thank you. And I guess, Ryan, I just received your risk adjustment response with the risk adjustment actuals that you gave us. Still reviewing things. It seems like 2020 came in a little better than you were expecting as far as less transfers. And I guess I was wondering if I could expect that to flow through to 2022 and cause those forecasted values to decline, by a similar amount.
Yeah, good question. I think in part, yes. I think we've been looking at it and have some, because they make changes to the risk adjustment formula every year. So I think I've seen some indication that kind of if you take the 2022 formula and back apply it, it would have still been better than we expected, but not by as much. So I think the way to think about it is, yeah, definitely some of that improvement can flow forward, but I think because of the changes that we know are happening to the process, I don't think it would necessarily all flow forward.
Yeah, that makes sense that it's not
Yep.
100% one-to-one, but
Yep.
directionally. So yeah, my team will follow up with you via surf on
Yep.
that. And I guess if you have any update on how COVID is impacting claims in emerging 2021 experience that you could share.
Yeah, I think I'd probably have to get back to you on that. I think, because even in Maryland, somewhat later in 2020, there was still impact. Obviously, as I said in my comments, the biggest impact was in those kind of March through June months. But it seems like now we're kind of more back to our, pretty close to our usual kind of baseline of what we would have normally expected.
Yeah, and the normalization factors you gave us, you were showing impact all the way through December, but you do think as of first quarter 2021, you're back to the normal claims level?
Pretty much, yeah.
Okay. All right, those are all the questions I had. Henry or anyone else from the MIA?
I'm good. Thanks.
Thank you.
Okay, well, thank you very much. Appreciate your presentation today. I don't have any questions. So Brad, before we move on to the individuals who have asked to speak today, let me ask you to do 2 things. First, if you could just perhaps speak a little bit more, probably to the risk adjustment impacts. I want to make sure that folks who are here have a bit of an understanding of what that means, since a number of carriers have addressed it as a consideration in their rating decisions.
Sure. At a high level, risk adjustment is kind of a linchpin of the ACA. Because the marketplace is guaranteed issue and guaranteed renewable, and carriers can't control the risk of who they attract, risk adjustment serves to transfer funds from carriers that have healthier than average members to carriers that have sicker than average members. So, in general, some carriers seem to fall solidly on one side or the other. Some carriers are always consistently much healthier than average and paying into the risk adjustment program. Other carriers are consistently much sicker than average and receive money from the risk adjustment program. And some carriers, especially larger carriers, you're pretty close to the pool average, and you could go either way as being a slight payer or a slight receiver. And so this is one of the hardest parts of the rate filings, the ACA rate filings, to project, because a carrier has to project not only their own claims, but they have to project their relative level of risk compared to all the other competitors. And complicating things is that the CMS is continually trying to improve this risk adjustment model. So each year they are issuing updated coefficients and or changing the models in additional ways. And so part of what happened with this year in particular was that CMS had some ambitious changes. They were making, you know, a handful of pretty significant changes to the model that would have really shifted the transfer amounts. And they got cold feet at the last minute and backed away from those changes and put them, you know, for future consideration. But so, you know, in general, this is something with a lot of variability that it is difficult for the carriers to project. And so there's always a lot of effort and focus on it. And, you know, especially for those carriers that have a history of flipping back and forth between a payer and a receiver, you know, that slight difference can have an outsized rate impact, because if you're receiving money, you know, that's lowering your rates. If you're paying into the program, that's increasing your rates. And so there can be a decent sized shift from year to year. And, you know, with respect to the individual market, there's also interaction with the reinsurance program. And so, you know, there is actions being taken to try to minimize that overlap between risk adjustment and reinsurance. You know, we compute a dampening factor that is applied to, you know, adjust risk adjustment for the amount that reinsurance is already covering. But to Pete's point that, you know, earlier in the presentation, that like because the PPO morbidity is worsening, it's getting higher risk adjustment and higher reinsurance, and it's coming out better. You know, that's more of a function of the risk adjustment side than the reinsurance side. Even in states with no reinsurance, you know, the risk adjustment seems to over transfer for extreme risk. And so carriers that do have a disproportionate amount of very sick members seem to get, you know, a transfer that is more than adequate to cover those members' sick claims. And so that's the dynamic going on here. And so if anybody, you know, did I answer your questions, Kathleen? Is that
You
fair?
did. I appreciate it very much, and it's a very complex subject. But as you say, it's a linchpin of the ACA. It's also, I wanted you to address it because it can be counterintuitive for people to say, well, gee, your population is healthier, your costs are lower. Why aren't your rates going down even further? And part of the answer to that is because there is literally a price to pay when your population is healthier, because what the ACA does is it adjusts for differences in risks among carriers. We tend to talk about things in terms of the market as a whole, but that market is broken down among individual carriers with individual products. And so part of what the risk adjustment does is it sort of evens, not completely, but evens some of that out. So I wanted to underscore that, because I know that there were some questions in the chat room as well about, you know, how, you know, if populations are healthier and costs are lower, why aren't we seeing more reductions? And that's one factor to consider, but one that's not necessarily talked about a lot. So thank you for the education. I think hopefully that helps people understand some of that dynamic.
No problem.
There was one other question in the chat room that I wanted to make sure that we addressed before we heard from individuals, and that is the question about why carriers, and there's an assumption in this question that carriers have similar experiences and are using fairly consistent assumption, why there's such divergent requests. So if you could sort of, I know at a high level it would have to be, but sort of talk about the fact that why do we see real differences between carriers which might have similar experience?
Yeah, I'll say that, that there are similarities between the carriers, like the COVID decline, that's something that all the carriers saw, but there are a lot of moving pieces that go into a rate increase, and carriers can be similar in many of them, but something like risk adjustment, where if one carrier was right on last year with their risk adjustment projection and predicted accurately where they're at, and another carrier, flipped from being a receiver to being a payer and didn't properly account for that, that one assumption can cause, a 10 to 15% difference in those two carriers as far as the needed increases. And so, it really is, each carrier's filings are unique, and we are reviewing each carrier's filings, separately. We do keep track of things that are market-wide total. We like to have the aggregate market data and know what the market is doing. But each carrier's filings, definitely rely on that carrier's actual assumptions. We have detailed, I could go through each and every carrier and tell you exactly what assumptions, are driving the increase, and it's going to be a different set of assumptions for each carrier. But I guess I would just say that the differences outweighs the similarities, and there are reasons for some carriers to be giving increases and other carriers to be giving decreases, and a large part of that is how accurately they have been in the past at projecting where the 2021 rate level is, because as Pete said, even though the experience period for this filing that we're looking at is 2020 dealing with COVID, the year over year increase is how these 2022 rates compare to 2021 rates. So a big part of everybody's increase is how well they did at 2021, and that's still an emerging question. We have half a year of 2021 data, so we still don't know exactly how good the carriers did. But even based on that half a year of data, different carriers were more or less successful at projecting where the rates needed to be in 2021, and that's flowing through to 2022 as well.
Thank you, Brad. I know that's a complicated question, so thank you for addressing it. Let me now invite folks who have signed up to speak. The first people that signed up were Gwendolyn and Raymond Benton. I don't know if Mr. and Mrs., I'm assuming Mr. and Mrs., but if the Bentons are on the phone or on the line, would like to speak.
Ms. Benton, would you like to speak?
That my understanding is that their question may have been about Medicare sub policies, which are not the subject of ACA rate filing. So we are very, very happy to talk to the Bentons offline if they do have questions about that other product. And let's see, the next person who signed up to speak was Stephanie Clapper from the Maryland Citizens Health Initiative Education Fund. So Ms. Clapper, welcome.
Thank you, Commissioner, for this opportunity to comment on the proposed Affordable Care Act health insurance premium rates for 2022. I am Deputy Director at Maryland Citizens Health Initiative, and we thank the Maryland Insurance Administration for its role in helping Marylanders access quality, affordable health care. In considering the proposed rates, we can encourage the MIA to continue to protect consumers and reduce the high cost of premiums. And as we look to the future of the marketplace, we should aim to continue to increase access and affordability in order to improve health equity, as Black and Brown people tend to have lower rates of health coverage while also suffering disproportionately from health conditions like COVID-19. The reinsurance program has been a great success in Maryland, helping to stabilize rates in the individual market over the past few years. And we think that it's important that Maryland continue this program in the years to come, and also continue to build onto other measures, such as the Easy Enrollment program, which connects Marylanders to health coverage when they fill out their tax return, as well as the newly passed legislation, which will connect unemployed Marylanders with coverage through their unemployment forms. Out of this year's legislative session, we are also excited about the new Young Adult Subsidy Pilot Program, which over the next 2 years will help Marylanders 18 to 34 afford health coverage. As we have seen over the past year and was discussed during this hearing, encouraging young and healthy Marylanders into the market will help to further stabilize the market for everyone else. This program is also expected to improve health equity, as young adults are the age group most likely to be uninsured in Maryland, and Black and brown young people are uninsured at higher rates than white young people. We will be working to get the word out about this program and look forward to seeing its impact over the next 2 years and hopefully beyond 2 years if the program is continued. It is important that Maryland continue to work to reduce healthcare costs to stabilize premiums, and so no discussion about affordability would be complete without examining high-cost prescription drugs. Maryland's Prescription Drug Affordability Board is tasked with evaluating expensive drugs and recommending appropriate methods for addressing these costs, including setting upper payment limits on what Marylanders would pay for them, which in the long term should result in more stabilized premiums overall. We'd like to request that next year, if you do decide to meet in person for this hearing, as was done before the COVID-19 pandemic, that you consider continuing to also make it accessible by Zoom or phone for the sake of members of the public with challenges like distance, lack of access to transportation, and disability. Thank you once again for this opportunity to comment, Commissioner, and for doing everything in your power to bring down premiums for Marylanders across the state, moving the state closer to having quality, affordable health coverage for all.
Ms. Clapper, thank you for your comments. They are very well taken. And I think a big shout out to the Maryland Health Benefit Exchange, our partner, which has done such a terrific job in terms of the special enrollment period and is really doing all of the heavy lifting as it relates to the new enrollment programs and the young adult subsidy. So we really are very beholden to the exchange for all the good work that it's doing. So I want to make sure that we understand that they're doing the heavy lifting on those things. But thank you for that. And absolutely. So we will at some point in time return to in-person hearings for all of our large informational hearings, but we will not do so until we have outfitted the MIA with hybrid capacity. So we are actually working with a vendor now to make sure that our hearing room is set up in a way that we can always be in a hybrid format. Because it is really important to, and it's been wonderful, frankly, to see how many more people have been engaged and how many more people have been involved because we have been able to do things virtually. So we're never going to let that go away. So thank you.
Thank you. That's really great to hear.
Absolutely. So I think we had one additional person that had indicated that they would like to speak. Nancy Raswad from.
Hi, thank you, Commissioner. Monty Rossman from the Maryland Hospital Association. And
I apologize.
No worries at all. Thank you. Appreciate it. So I'll be brief today. I want to thank the Commissioner and the MIA team, as always, for your open process here with the rate review. We comment every year, but I do want to note, at the outset that the summary that was released as part of the rate filings information to the public was much more in depth this year. So we really appreciate that. I think that's yet another way to ensure that you've got public engaged and more educated on how this process works, because everyone knows that it is so complex. We would encourage more opportunities for public engagement and more transparency in this process. Again, we've seen that year over year, and we're thankful for that happening. But anything additional that the Insurance Administration can think about in this space is always welcome. So I'll start out where I do it every year, just noting that the Insurance Administration, we hope, is in communication with the Health Services Cost Review Commission. And analyzing the trends, again, we see variability both from the hospital inpatient and outpatient cost and utilization trends. Between that and what was approved by the HSCRC last month, which was a total allowable revenue growth of 2.44%, and completely understand that those composite trends that are reported by the carriers have several other factors that are embedded in it. But we do believe that there is opportunity to understand and again, have more transparency around how that total allowable revenue growth rate is actually factored into the analysis on the MIA end regarding rate review. The other thing I want to flag is, again, we've got a national carrier who has in the written description inserted some boilerplate language around cost shifting being part of the underlying assumptions. And in Maryland, we have virtually no cost shifting between public and private payers. I think at this point, it's less about the words that are on the page and more about confirming from that carrier whether in fact they do include cost shifting as part of their assumptions. And if they do, they need to speak about that, I think, in these forums. And if not, then that should be something that should be made public, because it is concerning to see that in our state where we have an all-payer model. The other thing I think I want to flag here, most importantly, is that the requested changes do have some significant increases in what we're seeing in the filings, and understand the hydraulics around the 3 R's and how premiums are impacted when you have changes in risk adjustment, and that we're hearing that the reinsurance program has done its job. But so because of that, we've long advocated for more than just a reinsurance program to try to address high cost and high utilization. Specifically, we need to look at populations that have high healthcare utilization and try to understand how we can better control or better manage those populations. Recognize again that not anything is going to have the type of impact that a several $100 million reinsurance program would. But at the same time, there is much more that can be done in the space of care management on behalf of carriers. And so I know in years past, we've seen from the MIA some data that are reported on the wellness programs that carriers have in place. Don't know if we have that information available for us today at this rate review hearing, but I think more importantly than just the programs that exist are really understanding what the impact of those programs are, right? How have they improved morbidity? How have they improved access to care, particularly when we're thinking about on a hospital and I think statewide, the next phase of our total cost of care model, that is all focused on population health. And there needs to be more alignment related to what our carriers are doing on the end of coverage and care management to what is happening on the hospital end and the care delivery end, specifically on issues related to diabetes, opioid and substance use disorder, and maternal health, knowing that those are really our population health goals. So I again offer that as food for thought. We always welcome any conversations with the MIA, and you will see written comments from the from the Hospital Association here in the coming weeks. But with that, I can stop, see if there's any questions.
Brad, did you have any comments?
Yeah, I mean, I'll just make a comment that we do definitely take into account the HSCRC, hospital setting, and as you point out, a lot of the trends that are being filed are higher and different than the HSCRC, and that's driven by a couple different factors. Obviously, the overall trend is driven heavily by drug costs, which is outside the scope. But even the inpatient and outpatient trend, the HSCRC sets the global budget, but when you're looking at any subcomponent of members, you can have trends that utilization can run either higher or lower than the population at large. And so, I would say we use the HSCRC data, the factor updates as a base point. And if the carriers want to use something higher than that, they need to show in their data that, their population has utilization increasing at a faster pace than the global average. And I will say that the trends being filed are all still under review and may not be the final approved trends, and it is something that we're heavily focused on, and it is still, they are still numbers in flux, the proposed trend factors. I don't have any specific questions for you though, but I just wanted to respond to some of what you said there. But thank you for your testimony.
Yeah, absolutely. Yeah, thank you very much. All those points are very well taken. And some, each of those are things, some of which relate directly to rate, as Brad explained, what we do consider. And, talking more generally in terms of it is to everyone's benefit to really look at what drives increases in the need for utilization, high utilization in generally and in certain populations. And so that concept of care management and addressing social determinants of health are uppermost in everyone's mind. So yes, and we, as you know from our last listening session, we, along with other state agencies and other groups, are looking at what is the role that insurance properly plays in addressing those needs. And so the MIA is actively engaged with its partner agencies in looking into those questions. And wellness is part of that, So we have lots of conversations to come on what is wellness, like how broad is the concept of wellness? Does wellness include, the free ride to the clinic because that's the only way you get there? Does wellness include food, as medicine? Because if you don't have access to fresh fruits and fresh vegetables and healthy foods, how can you be healthy? So there are lots of concepts that are brewing, and we're happy to partner with you and others in looking at how we can effectively drive change within our regulatory construct.
Fantastic. Thank you so much, Commissioner, and we appreciate that partnership, and we'll look forward to more opportunities.
Thank you. So, Craig, I don't know if anyone else has asked to speak.
No, I'm not seeing anyone else.
Delegate Lewis Young, I know that you are with us today. I wanted to make sure if you had any additional questions or concerns that you had the opportunity to speak if you wish to be heard. Okay. So not seeing anything from anybody else. So,
Hi.
Delegate, hi, how are you? Thank
Good.
you
How
for
are
coming
you?
on.
Oh, my pleasure. This is so complex. I figured I wanted to get an early start so that I could absorb all this information. But no, I put all my questions in the chat. You've done a wonderful job at responding to them. Thanks so much. I'm very appreciative.
Absolutely. And, if you have additional questions or concerns or something pops up, please just let us know. I'm sure that Mike Patty, our Director of Government Relations. You can always reach out to him, and obviously you will have Brad's contact information. So, but thanks for being engaged today. I appreciate it.
Thank you.
So I think that brings us then to the end of our presentation. We've heard from everybody. It doesn't look like anybody else is asking to speak. So that will close the hearing for us. I want to thank everybody for their participation. As indicated, the hearing and all the materials submitted will be available on the MIA's website. And if you have any additional comments or questions, we're now going to put up a screen with contact information. Someone had asked whether it was August 6th or August 14th. The answer is August 14th. So we will collect comments through August 14th. And I think we'll see up on the screen the contact information slide. And we'll leave that up for a little bit. So general inquiries to Mr. I, anything, questions about rates to Mr. Boven, and then the link there for public comments. So Brad, thank you for your good work today. And thank you, Craig, for moderating for us today. And that will close out this hearing. Thank you.
Thank you.